Welcome to this educational video for sports trainers and medical professionals. In this session, we will cover shoulder dislocations, a common and complex injury in basketball. We will discuss the nature and causes of the injury, how to assess and manage it, stages of rehabilitation, and important factors for a safe return to play. A shoulder dislocation occurs when the head of the upper bone, humerus, is forced out of its socket in the shoulder blade, glenoid cavity. The glenohumeral joint, a highly mobile ball and socket joint, is particularly prone to dislocations due to its wide range of motion. There are three main types of shoulder dislocations, classified based on the direction of the humeral head displacement. The most common, accounting for 95% of cases, is an anterior dislocation, where the humeral head is displaced forward out of the socket. This usually occurs when the arm is abducted, moved away from the body, and externally rotated outward, often as a result of trauma, like a fall or direct impact. Posterior dislocations, which are much rarer and account for 3% of cases, occur when the humeral head is displaced backwards, typically caused by seizures, electric shocks, or falls onto an internally rotated arm. The rarest type, inferior dislocation, involves the humeral head being pushed downward below the socket, usually due to extreme hyperabduction that stretches or tears the surrounding ligaments and joint capsule. In this video, we will be focusing on anterior shoulder dislocations, which are the most frequent type in basketball. Symptoms of a shoulder dislocation include severe pain, visible deformity, and limited mobility. Swelling and bruising develop quickly, while nerve or blood vessel involvement can lead to numbness, tingling, or discoloration in the arm or hand. So how does a shoulder dislocation occur in basketball? Basketball is a high-intensity sport, and shoulder dislocations often result from its physical demands and rapid dynamic movements. A player diving for a loose ball, colliding mid-air during a rebound, or falling after a layup can create enough force to displace the humeral head from its socket. Even seemingly routine actions like reaching for a pass or blocking a shot can overstretch the shoulder, while repeated strain over time weakens the joint, increasing the risk of dislocation. These scenarios highlight the shoulder's vulnerability in basketball and the need for proper assessment, treatment, and rehabilitation for a safe return to play. Now that we understand how shoulder dislocations can occur in basketball, let's look at how to assess and manage the injury on the court. Imagine a scenario where a player is boxing out during a rebound and an opponent pulls on their arm while they're reaching overhead. This sudden force, combined with a vulnerable arm position, can cause a shoulder to dislocate. When assessing a suspected shoulder dislocation, we can use the toe taps framework to ensure a thorough and structured evaluation of the injury. Begin with talk by asking the player questions to gather information about the injury. For example, you may ask, "What happened? Where does it hurt? Did you hear or feel a pop?" Follow this by carefully observing the player's posture and arm position. Look for key signs such as a flattened shoulder contour, where the rounded shape of the shoulder appears sunken in the front. The player will often hold their arm slightly away from their body in an abducted position, or cradle it to elevate pain. Swelling or bruising around the shoulder joint may also be visible, developing soon after the injury. Restricted movement is common, as the player may be unable to lift or rotate their arm due to discomfort and instability. Next, perform a neurovascular assessment as part of the touch step, which is critical in anterior dislocations. Lightly touch the skin of the arm and hand, focusing on areas like the deltoid region, to check for any loss of sensation that could indicate nerve damage. Assess circulation by feeling for a strong radial pulse at the wrist, and observing the color and temperature of the hand to ensure adequate blood flow. If you detect any signs of nerve or vascular compromise, such as numbness, tingling, or discoloration, immediate medical attention is required. It is important to note that you should not perform active or passive movement of the shoulder, as doing so may risk further injury to the joint, surrounding ligaments, or nerves. After assessing the injury, we can now move to immediate treatments to stabilize the shoulder and reduce discomfort. The first step is immobilizing the joint. Gently place the arm in a sling or support it in a comfortable position to prevent further movement and minimize strain on the surrounding muscles and ligaments. Proper immobilization is essential to protect the joint until professional care is available. Next, apply ice therapy over the front of the shoulder for 15 to 20 minutes to reduce swelling and inflammation. Use a cloth or towel as a barrier between the ice and the skin to avoid frostbite. Be sure to monitor the player's response to ensure the ice does not increase pain or discomfort. It is critical not to attempt relocating the joint on the court unless you are specifically trained to do so. Anterior shoulder dislocations carry significant risk if mishandled, including potential damage to nerves, blood vessels, or soft tissues. Instead, focus on stabilizing the shoulder and ensure the player is referred to a medical professional immediately for imaging, reduction, and further treatment. The rehabilitation process for anterior shoulder dislocation begins with progressive mobilization. The initial phase focuses on restoring pain-free range of motion, which is essential for preventing stiffness caused by immobilization, while ensuring the shoulder heals properly. One effective exercise for this phase is the pendulum swing. To perform this, lean forward, allow the arm to hang freely, and gently swing it in small circles. This promotes gentle mobility while avoiding stress on the joint. Early mobility is crucial for restoring basic functional movements, such as dribbling or catching the ball with basketball. As the athlete progresses, stretching exercises such as static stretches and PNF help restore flexibility and reduce scar tissue. PNF stretches performed with a partner or therapist are especially effective for improving shoulder flexibility, critical for basketball movements like shooting and rebounding. Strengthening the rotator cuff is essential for joint stability, especially for basketball's overhead and multi-directional demands. Start with isometric exercises like towel and turning rotations to activate the subcapularis. Progress to resistance training using bands or cables for internal and external rotations, mimicking shooting and passing mechanics. Dynamic drills like overhead wall dribbles build endurance and control. Avoid high-risk movements such as abduction or uncontrolled overhead motions. Maintaining cardiovascular fitness is also key. Low-impact activities like stationary cycling or light elliptical work keep the athlete in shape without straining the shoulder. As rehabilitation progresses, sport-specific training becomes a focus. These drills are designed to rebuild confidence and the skills necessary for basketball performance. Shooting drills, for example, can begin with free throws to emphasize form and controlled shoulder movement, and gradually progress to jump shots. Passing drills should start with chest passes and later incorporate overhead passes as strength improves. Agility drills such as defensive slice or cone drills help simulate on-court movements while keeping the shoulder safe. These activities are essential for restoring coordination and preparing the athlete for real game scenarios, such as shooting, passing, and defending. Heat and cold therapy is crucial for pain management and recovery. Cold therapy reduces swelling in the early stages, while heat therapy improves blood flow and tissue elasticity before exercises. For example, ice packs after training reduce inflammation, and heat packs before stretching loosen the joint and tissues. This approach prepares the shoulder for basketball's demands while minimizing setbacks. Returning to play after a shoulder dislocation requires a thorough assessment to ensure the athlete is physically and mentally ready for safe performance. Key indicators must be met before clearing. The athlete must be able to perform all basketball-specific actions like shooting, passing, rebounding, and defending without any pain. Pain-free movement shows the shoulder has healed enough to handle the demands of the game. This might be three-point practices or free throw drills. Confidence in the shoulder stability is just as important as physical recovery. Fear or hesitation can increase the chance of re-injury. Psychological readiness is assessed using tools like the Tampa scale. A score of 17 or lower indicates no fear. The athlete can practice contact drills such as blocking the shoulder to build confidence in their shoulder strength and stability. Before returning to full gameplay, the athlete must be cleared by a medical professional. This clearance is based on successful completion of physical tests, functional assessments, and psychological readiness evaluations, allowing the athlete to play to his best of his ability. Basketball players often face pressure to return to play quickly, with elite athletes experiencing greater intensity. This pressure comes from two main sources. Internal pressure arises from the athlete's personal goals, commitment to the team, and desire to compete. Recovering players may feel the need to return quickly to avoid letting teammates, coaches, or fans down. Frustration about being sidelined can lead to risky decisions like downplaying symptoms or rushing rehab. External pressure stems from expectations of coaches, teammates, fans, or career concerns. Coaches may push key players to return early, especially if they hold crucial roles. Painkillers present ethical challenges in recovery. Pain signals injury, and masking it with medication can lead to re-injury. Ethical use. Over-the-counter medications for minor discomfort are acceptable if used under medical guidance. Strong painkillers like opioids can give false sense of readiness, leading to premature returns and risk repeat dislocations, permanent damage, or dependency. Prioritizing long-term health over short-term gains is crucial to avoid serious consequences. In summary, managing a shoulder dislocation in basketball requires immediate and appropriate care, a structured and progressive rehabilitation plan, and careful assessment before returning to play. By adhering to these processes, we can ensure the athlete's safety and long-term success on the field.